Here we have a patient that's presented with plantar midfoot pain, and the first step of the tissue stress model is to identify the stressed tissues. This is largely based on the location of symptoms, the type of pain, when the pain presents, the severity, and listening to the patient and establishing what makes the pain better and worse. We need to listen to what our patient tells us, so the subjective information is really important. So in this case, our patient has reported that their midfoot pain is aggravated with weight-bearing activities. It makes me suspect that it's mechanical in nature. Things that make it better are prolonged periods of rest and wearing supportive shoes. That again makes me suspect that it's mechanically induced pain. The second stage of the tissue stress model is to replicate symptoms, and we do this by applying various stresses to the involved tissues. The midfoot is anatomically quite complex, but the patient's reporting plantar midfoot pain. So in this case, I'm going to palpate the plantar fascia. I do this by dorsiflexing the toe, making the plantar fascia prominent and palpating along its course. Now the patient is reporting pain, and that makes me now suspect that plantar fasciitis is the condition at hand, but I'll also perform some muscle testing so I can rule in or rule out whether the tibialis posterior or flexor hallucis longus or digitorum longus is involved. I may even compress the calcaneus and fat pad to rule out a stress fracture or fat pad contusion, and I'll perform some other diagnostic tests. But at this stage, I'm suspicious it's plantar fasciitis. And in this situation, we want to also conduct some weight-bearing tests that are relevant to the tissue that we suspect is involved, which is the plantar fascia. So with this case in mind, we'll get the patient to hop and also perform some calf raises. And while performing these weight-bearing assessments, we're constantly asking our patient whether we're reproducing their symptoms. They may not always reproduce symptoms because some conditions actually are more painful after activity, but we need to keep this in mind.
Application of stress to the involved tissues can also be conducted through static standing, walking, and where relevant, running. Whilst conducting these tests, it's important that you gauge feedback from your patient to see if you are indeed replicating their symptoms.
It's important that your weight-bearing assessment and application of stress involves a static assessment of foot posture. And in this case, we can see that the feet are both pronated, and we know that pronation applies a stress to the plantar fascia. You'll also need to watch your patient walk, so you can observe if movements occur during gait that are relevant to their condition. And you'll also need to watch them run and see if you can see any biomechanical attributes during running that may be contributing to their pain. The running component is only important if your patient indeed runs. If they don't run, then it's not necessary.
In this case, we've determined that the patient's pain is mechanically induced. We've also conducted our weight-bearing lower limb and foot biomechanical assessment by watching our patient stand, walk and run. It's now important that we factor in other possible causes of their pain. This would include a non-weight-bearing biomechanical assessment, as well as potentially some additional weight-bearing assessments. It's important that as a practitioner you work out whether lack of foot and lower limb mobility plays a part. You'll need to assess the patient's flexibility. You'll need to consider whether their muscle strength and or endurance is relevant to the case. You should factor in their activity levels. You would have gathered lots of information during your subjective assessment of the patient. And once you've gathered all this information, we'll need to determine the etiological factors that we think were most relevant to the case. This is important because our management plan will need to address these issues. Now it's time to establish our management plan, and in this case, because we're dealing with plantar fasciitis, we need to first of all reduce tissue stress on the plantar fascia. I would consider offering the patient some advice around activity levels. This may include a period of rest. I would offer advice around footwear that would specifically target offloading the plantar fascia. That means the shoes will need to have adequate midfoot support and also possibly having some form of elevated heel. I would use some taping techniques that would protect the plantar fascia, and I would consider orthosis in this case because the patient also has foot pronation. I'd then move on to providing the patient with some symptomatic relief. This may include using simple things like ice, possibly anti-inflammatories, and in some cases even cortisone injections. A real important point is to consider the factors that we think cause this person's pain in the first instance, and we need to address those etiological risk factors. So for example, if the patient in this case had pronated feet, they lacked calf strength and they had a stiff midfoot, then my treatment would target those 3 key areas. Finally, we need to start to plan for a return to activity. This may include an activity to work or to sport. It's really just trying to get them back to living the life that they want to live and they were probably living prior to the injury. And like with any treatment plan, we need to be able to review and modify the plan as required, as it doesn't always go as expected.